Hi, my name is Kari Dyb, and today I'm going to talk about implementations theory. So how can we work together and kind of sort out the relationship between expectations and realities? One way of sorting things out are to systematize it. It's to make frameworks, to categorize, to make structures or theories about how technology are adapted or not into healthcare. Today I will talk about one of these implementation theories. It's called the NAS framework. And the NAS framework can help, and it can help predict and also evaluate the implementation of e-health in healthcare. It is developed by the University of Oxford with Greenhalgh et al. In the field of e-health, there are some implementation frameworks, not many, but we are steadily developing new frameworks. You can say this is work in progress, as e-health is a pretty new field in social science as well. And this is an illustration that Greenhalgh et al. Have made. It is quite complex, so I'll go through it with you later on, step by step. But the main idea is that there are 7 domains that affect the implementation of new technology in healthcare. And similar to that, there are 7 domains. It also depends on the complexity within each domain. The more complex the domain is, the more complex it is to implement a technology successfully. Yeah, I'm just going to go quickly through the domains. It is the condition, which it's about the health condition. So in my case, it's COPD and frail elderly with chronic diseases. Then it is technology, and it is something Greenhalgh calls the value proposition. It's also the adapters are seen as one domain, the organization, the wider system, and the interaction between the domains. By applying the framework to projects, the idea is that NAS can contribute both to inform the design of the new technology. It can also identify technological solutions that, perhaps despite policy or industry enthusiasm, have a limited chance of achieving large-scale sustained adoption. It can also contribute to planned implementation, scale-up or roll-off of technology programs. And last but not least, it can explain and learn from program failures. So then we'll go back to the NAS framework. I don't know if you remember, but the first domain is the condition. And what you're looking for then is what is the nature of the condition? Are there any comorbidities? What is the social culture influence of the condition? And in our case, it was COPD and also frail elderly with complex long-term illnesses. And within NAS, you kind of evaluate or assess, is the condition simple? Is it complicated or is it complex? And in this case, we can see here, this is a quote for one of the participants, and the person said, "I think it's best suited for patients in early stages of COPD. However, very ill patient need it even more." So we have, or at least our assessment is that they didn't, or the healthcare personnel did not see COPD or healthcare or the condition of frail elderly with chronic diseases as complex or complicated. It was quite simple, but they also you can see, or from this quote, you can kind of interpret that they see it is easier for the patient that are not having that severe COPD. And when it comes to the technology, it's the same thing. You kind of evaluate it on a scale from simple to complex, and you look what is the material feature, the type of data generated, the technology support models, etc. In our case, it was iPads and COPD monitoring equipment in patients' home. And at the telemedicine centers, it was monitoring data, or they monitored the same data that they got from the patients. It was also video consultations and electronic health records, and these were placed in telemedicine centers. And here is a quote from one of the healthcare professionals, which says, "If the patient is not able to touch the screen of the iPad and the green telephone icon, we are able to oversteer it. So the patient only needs to sit down in front of the iPad." So you can see that the health professionals, they didn't find technology complicated at all. If there were any issues in the patient's home, they could oversteer it from the telemedicine center. This was at one of the innovation area they had this possibility, and they liked it very much. So we will regard this domain as simple within the framework. Then it comes to the value proposition. And in the value proposition, it's a question of, does the innovation give increased value for vendors and investors, but also for the hospitals, the municipalities, and the patients? This is quite interesting, because what we found was that across the 4 arenas, the true value proposition was improved quality of life for the patients. Across the arenas, healthcare professionals were much more concerned about the quality of life of the patient than they were for that this should kind of give increased value for vendors or investors. We have actually said that there was a mismatch between the value proposition across the arenas. There were some, so that's why I'm included this quote. There were some particular managers that were concerned about more the economical sustainability of the technology. But for most health professionals, it is the patient that is the core value of the technology development. So we have kind of said that the value proposition were complicated at all 4 arenas. Then the 4th domain is the adapters. What do the users, patients, relatives, and healthcare professionals think about the solution? And this was also quite interesting for us, because we have been studying e-health for at least 15 years. And most of the time we find that there are some health professionals that are, what should I say, they not favor the technology that much. They feel that it disrupts the professional relationships or disrupt the patient-provider relationship. But in 3P, they were all surprisingly positive. Most of the staff, in fact, all the informants in our study were positive towards technology-supported PCC. However, and this is quite kind of tricky, because since 3P promoted technology-supported patient-centered care, we are not quite sure if the health professionals favored person-centered care, or was it the technology dimension that they favored. So we have kind of said that We have labeled this domain as complicated because we are not quite sure what we are assessing here. Is it the combination of technology support and person-centered care that's the beneficial, they like so much, or is it technology support, or is it person-centered care? The fifth domain is about the organization. So we can say we are moving a step up from people to more the structural level of the innovation. How are the organizations? Are they ready for the innovation? What we found in our study is that several of the users or several of the health professionals use concepts like silo mentality or silo organization when they refer to division of labor and economic responsibility between primary and specialist care. We had at one of the arenas, the hospital was responsible for the innovation, but the service was provided in patient's home, and the staff that were involved in this organization were quite concerned that the hospital wouldn't prioritize this kind of services that was not demanded by law when it moved from project phase to use in everyday practice. Okay, I have included this quote to kind of show the complexity here. I'm not going to read it, I'm just going to give you can read it yourself, but I think this is quite interesting because it has to do about the power of money, in a way, because by the end of the day, you have to provide, or the organizations have to provide the services that they are demanded by law. So even if a project works very well and everyone is positive and happy, it must be economically sustainable to survive. So we have said that we will think we have categorized the fifth domain as complex. The sixth domain is the wider system. How is the broad institutional and socio-cultural context? This is also quite interesting because, at least in Norway, we have the national authorities, they are really promoting both person-centered care and e-health. The governmental support of e-health is visible in white papers and also in the funding. To get funding for pilot project is, I wouldn't say easy, but there is a push from the government to use technology. And the same goes for person-centered care. What we found in our study is that when you look at the regional or even local level, it is much more complicated. At one of the arenas, they had a system that functioned very well. It was for COPD patients, and the municipality had supported it for, I think it was about 3 years. They had supported it economically, but also promoted it, try to get patients to sign up for this kind of treatment, to live at home and get online support from a telemedicine center. However, there was a change in mayor in the municipality, and the new mayor and the new board of the municipality didn't support the e-health initiative. So their funding, they kind of was withdrawn. In another region, the telemedicine center was set up to serve several municipalities. This was small municipalities located in the southern part of Norway, And the idea was that if they could provide proper COPD care for patients in several municipalities by trained expert nurses, it would improve the overall treatment in the region. The challenge in this area was that the municipalities, when it came to money again, they had to consider how much does it cost us to pay for, say, 2 COPD patients in our community compared to hiring extra personnel. And when they talk about hiring extra personnel within the municipality, they said this had to be seen in a much wider context. It provided income, it provided taxes to the municipality, but it could also be important for keeping the kindergarten up or the schools in the area and up and running and stuff like that. So the idea here is to illustrate that the wider system of the service is really important for how the technology is implemented, or if the technology is implemented. So when it comes to the evaluation or the way we have kind of marked this, the wider system, we found it complex in all 4 arenas. Okay, so then we have finally arrived to the 7th domain, which is about embedding and adoption over time. And the main question in the NUS framework here is, how is the opportunity for development over time? The results from the innovations arenas is that 1 of the 4 arenas is an integrated part of clinical practice today, but in a modified version. 1 arena is completed. 2 arenas continues as projects, but 1 had to move municipality to kind of survive. So we have kind of labeled or when we're looking at the dimension, is it simple, complicated or complex, we would say that the 4th domain is complex. And this is an afterthought for us, because still healthcare professionals are optimistic. Despite all these challenges and all the complicatedness that we see when applying an NUS framework to the 4 empirical arenas, they believe the healthcare professionals involved in these 4 arenas, they really believed in technology-supported person-centered care. One of them said, there is no way around technology-supported person-centered care. It is here to stay. We found that the NUS framework was very useful as an analytical tool to understand what was actually going on in these different arenas. And also the dimensions from simple, complicated to complex is useful, and it's a good tool to use in communication with healthcare professionals and managers. It is quite simple, and it's something that people can relate to. At the same time, we will say that it is less suitable for conveying the enthusiasm of healthcare professionals. Despite all these challenges that we saw, the healthcare professional really loved the solutions. So to sum up, I would really promote frameworks for implementation studies. They are useful. They are useful in practical terms to kind of guide or support managers and healthcare professionals that are interested in implementing new technologies. But we also have to be aware that they are frameworks, and they are constantly under development. So we have to look at them as dynamic tools to kind of clean up the mess or clean up all the expectations that are within the field of e-health. We have to be realistic, and frameworks is one way to kind of systematize our knowledge and also the steps that is needed for successful implementation. Thank you.